Hello, my name is Saad Usmani. I am the Chief of the Myeloma Service at Memorial Sloan Kettering Cancer Center, and I'm here with blood cancer today. We are here in Chicago for the ASCO 2023 annual meeting, and we're going to be talking about all the exciting data coming out in multiple myeloma. We'll cover the newly diagnosed setting, some of the approaches to early as well as late relapses in the context of new novel immunotherapies, including bispecifics and CAR-Ts. So I'm looking forward to having a wonderful, engaging conversation with my colleagues. I'll let them introduce themselves.
Hi, I'm Yi Lin. I'm from Mayo Clinic in Rochester, Minnesota.
Hi, I'm Shambavi Richard. I'm from Mount Sinai, New York.
Hello, I'm Meera Mohan. I'm from the Medical College of Wisconsin.
I want to start by, asking you all about the newly diagnosed setting. Is there still a debate about whether to use 3 versus 4 drugs for induction?
Well, I think with the data that's been maturing from Griffin and Maya that we've seen, there's definitely a role for CD38 antibody up front, whether that's looking at transplant eligible or ineligible. And so definitely in our practice, we've been using a lot of quadruplets for our patients. And I would say in the patient that's being referred to us from the community setting, even more so in that situation.
And then Shambavi, what about Sinai? What are you guys doing?
Yeah, so my go-to has now become Dara-VRd after the Griffin. It's been pretty telling data. I still see patients referred from the community who are using triplets. So there's plenty of that, I think, still around. It hasn't quite, phased out yet, but certainly I think for the vast majority of my patients who are transplant eligible, I prefer to use the quad Dara-VRd.
And then for the transplant ineligible patients, is it like a mix between triplets, VRd versus DRd? What are you seeing?
So the Maya data, again, was really compelling. It was having amazing survival data and the PFS for the triplet DRd. We have an IIT in our institution where we use, with the Dara-VRd modified for older transplant ineligible patients. So we try to get them on that study, and if not, then if it's going to be just standard of care, I use the triplet DRd.
Okay, and Meera, what about Milwaukee?
It's kind of mixed, where, maybe 50-50. So if a patient has a high tumor burden or patient presents with renal failure where we have to bring down this light chains fast, we tend to use quadruples more, but otherwise it's kind of 50-50. For transplant ineligible, I think it's nearly Dara-RD, kind of 100% Dara-RD.
And then for the older patients, we also have, 2 randomized phase 3 studies that we're waiting on where, isatuximab has been combined with VRd, Dara has been combined with VRd compared to the triplet regimen. So I think, that data is maturing. It's not being presented at ASCO, but, I think we're all waiting for those data. But there is an abstract, looking at a quadruplet versus triplet that's being presented at ASCO. And interestingly, it's the, KRD or carfilzomib Lendex with or without elotuzumab for the transplant eligible patient population. So Meera, what do you think about those data?
Quite frankly, I was surprised to see the high MRD negative rates with ELO added to KRD. It's like around 50% at the 3-year mark. So I think it's the first time elotuzumab in combination with KRD has shown such impressive MRD negative.
Agreed. I think, there was another, German myeloma group randomized phase 3 that had looked at RVD with or without elotuzumab as induction for transplant-eligible patients, and we didn't see any difference. And then, in the US, there was the SWOG 1211 trial for high-risk patients where, RVD induction followed by RVD maintenance with or without elotuzumab was looked at, and, there was no, PFS or OS, difference. Even response rates were similar. So this is, quite interesting and not as intuitive. So, I'm looking forward to, getting more details on what that data looks like.